responsibility of each citizen and I come forward for this cause and help creating awareness around critical illness. It gives me immense pleasure to see all of you with us today on the eve of World Stroke Day, which is globally observed on October 29th, underscore the serious nature and high rate of stroke responsibility, raise awareness of the prevention and treatment of the condition, and ensure better care and support for survivors. On this day, organizations around the world have facilitated events emphasizing education, testing, and safely observe on the damaging effect of stroke worldwide. Talk about the prevalence of stroke at global level. According to the World Health Organization, stroke is the second leading cause of death and the third leading cause of disability, and 1 in every 4 people is prone to stroke. In our country, stroke poses a formidable threat and ranks among the top 5 causes of death. According to government estimates, incidence of stroke population varies from 116 to 163 per 1 lakh population. Through different studies have suggested the number to be as high as maybe 250 per 1 lakh population. The ICMR report entitled as India Health of the Nation's States also underlines stroke as the 4th leading cause of death. The WHO puts the annual figure in India to about 14 to 16 lakh new cases annually. So one of the most pressing cause of fatalities and disabilities due to stroke is a lack of awareness of its symptoms and the condition itself. Stroke is often referred in our country or confused with as heart attack, paralysis, attack, or even sometimes high blood pressure or brain hemorrhage. According to research, 12% of strokes in India occur in the population aged less than 40 years, and 1 out of every 3 patients have with the stroke do not have access to appropriate healthcare, probably due to difficulty in access to the right medical facilities, non-affordability, and uses of alternate medicines. Looking at the gravity of the situation, the Ministry of Health and Family Welfare, the Government of India, released guidelines for prevention and management of stroke in 2019. The guidelines include the clinical management of stroke, identifying the early symptoms, and the most importantly, the guidelines focuses on instructions on setting up stroke care facilities at the primary and secondary levels of Indian healthcare system. In this opening session of the summit, we will be discussing the vision to make a stroke-ready ecosystem in our country, implementation of government guidelines for integrating stroke care at the primary level of healthcare, capacity building of the healthcare workforce, from the first responders to paramedics, ambulance staff, primary healthcare professional, to making of stroke-ready hospitals. To get the conversation rolling on the need of India to be stroke-ready and to efficiently manage the stroke incidences with hands-on medical ecosystem, I have with me an array of esteemed expert panelists today with us. So let me welcome our panelists for this session. We are going to have Dr. Atul Mohan Kochar, CEO of NABH, a passionate advocate of quality healthcare for all. Dr. Atul has been a principal assessor with National Accreditation Board for Hospitals and Healthcare Providers since 2016. Presently, as CEO of the board, he is actively leading the mission of ensuring patient safety and taking the best healthcare practices to the poorest of the poor of our country. We have Dr. Jairaj Pandian, the President-elect of World Stroke Organization. Dr. Jairaj D. Pandian is a professor of neurology and dean at the Christian Medical College, Ludhiana, and the current President-elect of World Stroke Organization and immediate past President of Indian Stroke Association. Dr. Pandian has made significant contribution to stroke care services, epidemiology, and the thrombolysis in low and middle income countries. We also have with us Dr. Urvashi Prasad, the director at the Vice Chairman's Office in Niti Aayog. Urvashi has extensive experience in health, nutrition, sanitation, gender, and public policy. She is a passionate advocate of health equity in the country, complemented by affordable and accessible healthcare ecosystem. We also have Dr. Vineet Suri, senior consultant neurologist at Indraprasth Apollo Hospital in New Delhi. Dr. Suri is an experienced neurologist and stroke specialist with vast national and global experience in stroke management. He is the president-elect of the Indian Stroke. He is the present president, of the Indian Stroke Association. His core areas of interest include stroke, epilepsy, and neurological disorders. And last but not the least, we have Dr. Bindu Menon, the professor and head of Department of Neurology at Apollo Specialty Hospital in Nellore. Apart from being an excellent neurologist, he is a well-known health activist, researcher, academician, and philanthropist working to ensure free treatment to patients with neurological disorders in rural areas of our country through her organization called Dr. Bindu Menon Foundation. So welcome all our esteemed speakers, panelists, and experts at this fourth edition of Stroke Summit today. Let me begin with Dr. Suri. Dr. Suri, as a president of Indian Stroke Association, I would like to, request you to set the context of how much the burden of this condition we as a country have, and what are the, primary regions and trends you are seeing because of the increasing incidences of stroke in our country.
Can they get the best form of treatment? I think that's the challenge.
Thank you, Dr. Suri. So just a small follow-up question. You are practicing in Indraprasth Apollo Hospital in Delhi, and I'm sure, as you said, that the stroke care a lot is concentrated in our large cities, as for many other diseases also. But do you think that we have the enough awareness among the people and especially when it comes to early signs of stroke, so that people can actually seek the medical care or can report to a medical facility within that golden period of I think 4 hours it is in the context of stroke. How do you see that even in the urban areas or the areas which has enough support system, especially do we have all cases being addressed adequately when it comes to
very important.
early signs of stroke, so that people can actually
that even in
seek
cities
the
like Delhi,
medical
Bombay,
care
where
or
all
can
the
report to a medical facility within
the
that
awareness
golden
among
period
people
of
to
I think
identify
4 hours it is in
stroke
the
appropriately is poor.
context
And they
of
are not
stroke.
aware that they can
How
actually
do you
get a
see that
reperfusion therapy like an intravenous thrombolysis only within the first 4.5 hours. Very select patients can be selected up to 9 hours. So that window period of 4.5 hours is open up to 9 hours for a select patients, based on advanced imaging. Or they can get a mechanical thrombectomy up to 6 hours, and only a very few select people up to 24 hours. So these are the two windows one should remember. But one should remember that the earlier you get, even in the 4.5 hours, so somebody who gets the reperfusion at 1 hour will have a much better outcome than somebody who gets it within the window, but maybe at 4 hours. So this is what has to actually be known to everybody. Even, we have patients who are they're in a car across Apollo Hospital, they develop a stroke and they rush to the cardiac hospital next by thinking it's a cardiac attack. So brain attack, I think one should, there should be a general education to patients that, one, how to recognize stroke, and second, what to do when you have stroke. You have very little time. Don't waste your time going to a general physician or sitting at a CT scan center and trying to see whether it's a stroke or not. rush to a stroke-ready hospital where a reperfusion therapy can be done. Most of these hospitals have code fasts in place. They'll not waste time at all, and they will reperfuse quickly. So I think that mnemonic, which can go to the public, is be fast. B F A S T to recognize symptoms of stroke, where B means an abrupt onset of balance problem, a sudden onset of balance problem. E stands for a sudden onset of eye problem. Either it's a squinting or it's a loss of vision in one eye or loss of vision in one field of eye, that's on one side. F stands for a facial asymmetry. So when you're smiling and the face is drooping on one side. A is for an arm drift. So if you raise your arm and the arm is drifting down, and I would say A should also stand for another altered sensorium. So sudden onset of unconsciousness or drowsiness. And speech, S stands for speech, where if you have a sudden slurring of speech or inability to speak or inability to comprehend. So if you have B fast symptoms, it's a mnemonic to remember. You have to rush to the nearest stroke-ready hospital. Try to get the intravenous therapy, all the mechanical thrombectomy, whatever is required, as fast as you do not have 4.5 hours. The earlier you do it, the better will be the outcome.
The better. Thank you so much, Dr. Surya, and I'm sure that all the people who will be listening this will, kind of keep this be fast message in their mind and should be able to identify the occurrence of a stroke earlier and also seek the right care. Let me go to Dr. Bindu Menon. Dr. Menon, Dr. Suri talked about the concentration of the care again in certain pockets. But at the same time, there also just having the enough infrastructure does not help us get the right outcomes, because the lack of critical information and awareness among the masses and the people. From the rural perspective, or the areas which are not as such, because you are involved in a lot of work on those areas as well. What is your opinion in terms of we having enough infrastructure or facilities for stroke management, and also what is the scenario about the awareness? Because we do see the lack of awareness, the confusion with many other problems, and especially, as I said, paralysis, LACWA and all that is much higher, and even the tendency to seek alternative care instead of going to a medical facility is higher in those areas. So how do you see that there?
Thank you, Mr. Narayan, for having the opportunity to be on this panel. I completely agree that awareness is very low. But I would also want to point out that there could be a particular patient in an urban area across the street of Apollo who does not reach, though he knows that there is a facility available. And we could also have a particular patient in the rural center who's available, who knows that it is stroke. Now, integrating all the links, the person, most of the time it happens that they know that it is a stroke. But we have seen in our setting is that though they know it is a stroke, they do not rush to the hospital. One, because of the facility, they do not have to rush to the hospital, because the mode of transport and the distance between the facility where there is a stroke-ready hospital. So they end up landing in a smaller unit where they waste a lot of time, and then they sort of get dejected that this is a stroke and nothing can happen. The second point is that when we do our rural services, if I go into a rural area and I talk about be fast, it is really not possible for me to connect to the particular population because of the language bar. We know how India is, and across the areas, we all speak different languages, and also some of them do not understand English at all. So in our foundation, we had made a mnemonic out of the Hindi swaras, Sare Gama Pada Nisa, and we translated into all of those stroke mnemonics so that we could connect, because everybody knows a musical note and it is easier for us. I would also say that the difference between a cardiac attack and a brain attack is different, because the manifestation of a stroke is heterogeneous. It's just not a chest pain. Chest pain, go to the hospital, done. It's a cardiac attack. But in brain, some have a upper limb weakness, some just have a grip weakness, some just have a foot drop, some come with only dysphagia, just difficulty in swallowing, some have visual disturbance. So this heterogeneity of the manifestation of a stroke makes it difficult for us to connect to people, because it's really not it's a great challenge for every individual in your public awareness to make them understand about all the manifestation. Having said that, it is important to know your community where you are. And it is very important for us to get to the community at that level. And not only being aware of the stroke, it is not only recognition. We always impress and put it in point that you should respond and react to the stroke. Get to the hospital, big hospital with CT scan. And I am seeing that there is a change which is happening in the rural areas also, that people are reaching out faster. They don't know what it is, but they feel that it is something connected to the brain as an organ.
Thank you so much, Dr. Bindu. Important, I think this is also an important side that we need to coin our messages in a way which is most effectively reaching to the target audience, and they are understanding and able to connect with that. And I'm sure that this Saregam Padanisa would have, and that connect also. We would like go to the detail of it maybe a little later. Let me take Dr. Jairaj Pandian at this moment. Dr. Pandian, we will also talk about as your global role and what are the best practices. But before that, what is the from the institutional side of it? So there is an awareness which is an important issue to be addressed. Institutionally or from the system point of healthcare system point of view, what are the challenges you identify in terms of making our system robust and responsive to to the incidences of a stroke, and are capable in management of it?
Yeah, I think once they reach the hospital, that is where we need to have a proper stroke system of care, or the workflow we call. Patient reaches the emergency department either by their own conveyance or by an ambulance. And then from the emergency department, there has to be a rapid recognition, or I would say rapid evaluation of these patients. We should not waste time there. So that is where this concept of stroke code, which can be done in different ways. It could be a voice paging system, or it could be a mobile-based system or app-based system. So as soon as the patient comes in, everybody in the team, the emergency department staff, the radiology, the neurology team, or the physician and treating the stroke unit team. So everybody is alerted so that they know, even in the scan, if there is a CT scan going on for another patient, priority is given for this particular patient. So as soon as this is alerted, the rapid evaluation, that would take maybe 5 minutes, or just to check blood sugar, blood pressure, and quick what we call stroke severity assessment, and then ship the patient for the scan. And in the current protocol is CT angiogram. Even with place CT scan, we can make a diagnosis of small strokes as well as big strokes. So plain CT scan is sufficient. And once your scan is done, you should not wait for half an hour for reporting. You should not depend on radiologists. Even if there's a teleradiology, it has to be reported quickly. So that is where the artificial intelligence comes into play. There are some apps and softwares available which can be integrated to the PACS system, and the same team can see the images. Okay, the same app can trigger the stroke code also. So clinical details can be entered, and everybody in the team knows this patient is coming, CT scan is done now, and we have seen the images, patient's stroke severity is this much, there are no other exclusion criteria, and we can give thrombolytic agent in the CT scan also. If not, quickly in the stroke unit, but better to give in the CT scan itself, so that everybody is ready. There's a stroke tool kit and that will have everything, including the injection and all the things like measuring blood sugar, BP, apparatus, everything is there in the stroke kit. And then once you take a decision, this patient needs only thrombolysis, or more than that, if there is a large artery occlusion, then you need to do thrombectomy. And you need to alert the DSA lab and the entire intervention team. So once these procedures are done, they have to be in a stroke ICU or neuro ICU, and they have to be monitored. That is where the nurses' role come in, and most of the care is taken care by the nurses. There are standard evidence-based protocol available, like controlling fever, blood sugar, blood pressure, to prevent pneumonia, swallowing assessment, which can be done by the nurses. Even nurses can monitor whether patients are deteriorating or normal in the next 24 hours. And then you have all the other medical protocols, and then early rehabilitation. And at the time of discharge, you have a clear plan, and patients are integrated with the community, with the patient, the relatives, and then a proper plan for rehabilitation. This is a stroke workflow or continuum of care, and this is where we can do a lot. This is under our control, particularly the rapid evaluation. And if you narrow down all these time, for example, a simple door to CT time, if you make it, keep it minimum, door to needle time, if you keep it minimum, then the outcome improves automatically. So even if they arrive within 1 hour or 1.5 hours, if within the system, if we organize it very well, then we can still provide the right treatment, and the patient will improve.
Thank you so much, Dr. Pandian. This seems to be a very perfect, scenario where a very, I think, robust system you described, which has, all as infrastructural, I think, supports, as well as a very prompt, trained, efficient healthcare, manpower as well. Right from identifying, evaluation to the technicians involved, to even the nurses at the end of the towards the end of the care. How many hospitals in India are equipped with this kind of flow, who have all this system, toolkit properly laid down, trained? It's like the way in corporates we do, or in organizations we do fire drill. How many times this is kind of efficiently done? So do we have adequate number of hospitals and facilities, and preferably spread across the country, having this kind of flow?
Yeah, there are hospitals now. What I can say is, for the last more than 10 years, the stroke care in India in different hospitals improved. I can give you some rough numbers. We have the thrombolysis capable center, or a stroke ready center. We have close to 400 or more than 400, but probably within 500. The thrombectomy, mechanical thrombectomy capable centers around 300. And if you look at if you look at the system, healthcare system as a whole, largely it is in private sector hospitals. And there are many states. Currently, there are 7 states where we have this hub and spoke model, where there are 1 or 2 hubs which monitor the spoke hospital, and where physicians, they evaluate this patient in the district government hospital, and through telestroke, they are connected to the hub, and thrombolysis is given free of cost. So there are states like Punjab, Himachal Pradesh, Kerala, even Andhra Pradesh, not in a full-fledged way, at least to some extent we have, and there are efforts to expand it to other states. So your question about do we have hospitals? Yes, both in private and public we have, but this is not sufficient for the population of 1.4 billion. No, we need to have, as per whatever estimate that we have, we should have at least 1,400 stroke-ready hospitals, at least the thrombolysis centers.
Great. Thank you so much, Dr. Pandian, for highlighting this. Let me now take Dr. Atul Mohan Kochar at this point. Dr. Kochar is the CEO of NABH, and he is making many hospitals be ready to tackle many of the healthcare emergencies. So stroke can definitely be one of that. Dr. Kochar, how do you, from the NABH point of view, from an institution which is trying to enhance the overall quality of care in all kind of healthcare issues, stroke may require a very specific kind of quality, promptness, efficiency, and all those things, and even the trained manpower also. How do you see that? We can effectively bridge this gap from maybe 400 or 500 stroke-ready hospitals to 14 or 1,500, as Dr. Pandian is saying, and what kind of role maybe NABH or other government agencies can play into that?
So thank you, Kamalji. Thank you for giving me and NABH this opportunity to be here amongst stalwarts today. So we have already seen that how the stroke burden is a huge burden, needs sensitization, needs capacity building, and needs so much to be done in this area, starting from basic recognition of the symptom that be fast is a wonderful mnemonic, and there are others probably. But we need to disseminate that knowledge, then we need to take corrective action and build capacity, as Dr. Pandian very rightly pointed out. So just quickly, please, if you'll allow me, I'll just, to all the audience, would like to introduce what NABH is. So NABH is the National Accreditation Board for Hospitals and Healthcare Providers. We are 18 years young. We are under the Quality Council of India umbrella. And starting from the 2005, when it was formed under the QCI, we today touch about 18,500 hospitals. We add 250 hospitals every month, which are generally in tier 2, tier 3 cities under the certification program. And we add about 20 to 30 hospitals every month under the accreditation program, which is a flagship program. Today, we run about 27 programs, including some of the only kind in the world, like the Ayush program. We have specialty programs like the stroke certification standard. I'll just come to that. And we also run programs for the standalone diagnostic centers. We run programs for dermatology and aesthetic centers, and also for dialysis center. Whole lot, total about 27 programs. We have presence in 8 countries and lots of interest from many others, which follow our standards. So coming back to the stroke thing, our journey into the stroke certification standards development started about a year back when Dr. Pandian, along with Dr. Sheila Martins, invited us to the Brazil Global Stroke Alliance conference, which was held at Sao Paulo. And there we started to think, we saw firsthand how the WHO is making inroads into the Latin American countries, where there's lots of synergy between what the challenges which we feel in India and them. So based on that, it's been a year-long journey, and I'm very thankful to all the experts led by Dr. Jairaj, Dr. Martins, and a whole lot of our colleagues from India who have contributed to development of these standards. So what exactly are these standards? So standards, when we say they're published as a book. So this is a book which is available for free download from our website. So basically, a standard is a collection of best practices which are endorsed by, of course, for example, the national and the international best practices. They're the checklist based. So it's a focused approach to development of capacity, starting from capacity building to, from sensitization of the hospitals to the staff to everything, including public awareness. So it's just an approach which has stood the test of time. So I believe that NABH has been reasonably successful, or I think I'll not be modest. We touched, like I mentioned, about 18,500 hospitals, and out of this, 3,300, I can very proudly say, are islands of excellence with cutting edge technology. And majority of these, I think about nearly 2,000 hospitals would have some sort of stroke ready infrastructure which can be scaled up to a center of excellence. They may not be top of the notch, but they have the capacity to be rolled out. But the rest, the majority, the 15,000 nearly of these hospitals need to be, we have to start from the scratch. They have to be told something as basic as hand hygiene, probably, and communication safety, surgical safety, and then go on. So we have a wonderful opportunity here to reach out to these smaller hospitals and tell them all the nuances of such a deadly disease as a stroke. We all know that 1 rupee spent towards prevention of a stroke will save probably hundreds later on. So that's what NABH wishes to do. Wishes to invite all these stroke leaders, people who are leaders in the field of stroke, our leading neurologists, and everyone who's connected to the infra to join this mission. So we have to work in a mission mode. And NABH is just a platform with a focused approach, which has been, and these standards, as I mentioned, have been crafted by, they've gone through, they're very practical standards, they're very low cost standards, and they just provide an approach towards how we can jointly work towards handling this menace. So that's what NABH is. And so this is a basic invitation to adopt these things because it's very easy to bring out a standard or a set of guidelines to follow, right? But you need a oversight. You need a credible organization. We are part of the government infra, we are not into this for the revenue part. Dr. Jairaj will vouch for that. So these are extremely low cost standards, and we have kind of weaved in every aspect, starting from the best practice in the world, the rescue mission, to everything. Starting from whatever there is, and they are endorsed by the government also. So I would like to invite again all the probable stroke leaders who are joined in today to be part of our assessors. To be whatever. We hope to start very soon a series of sensitization capacity building programs down to the last in the line, down to the tier 2, tier 3, tier 4 cities. And so please help us take this mission to the people. So that's the request. And probably, it's going to take time from 450 to 4,500 is going to take probably lots of time. But like every step matters. So NABH is fully ready and geared up and motivated to do that. We just need the support of the entire community, which is helping fight this or sensitize people and the hospitals and the industry and the infra for this.
Wonderful to hear this, Dr. Kuchar, about the lot of efforts which NABH, along with World Stroke Organization and maybe Indian Stroke Organization as well, has already initiated. And I think this definitely going to help us bridge this, gap more efficiently and effectively sooner than later. Let's go to Dr. Urvashi Prasad. Urvashi is, I think she is having some connectivity issue through not the on video. Urvashi, are you there?
Yeah, I'm here
Okay,
on audio, but yeah.
Yes,
Yeah.
no problem. So as you heard about, the scenario, Dr. Kocher is working a lot in the area of making many of these institutions follow those important guidelines and protocols and standards. From the public health, planning point of view, Urvashi ji, and as the government of India and especially the health ministry has been quite, focused also from, our overall movement towards, achieving those SDG goals as well, along with those basic indicators. Government has been very proactive in terms of looking into NCD as an important area of intervention, and stroke do capture a large space in that. How do you see that public health policies can help in all these areas, from the public participation and awareness side to having a strong, robust institutional system where we have the right referral system for the patients who may have the occurrence of stroke, and to also have the enough number of stroke ready hospitals as identified our other experts.
Yes. So Kamalji, yeah, like you rightly said, and I think, the panel has also spoken about it, that there's many dimensions to this. It's obviously a very complex issue. And I think for us, like in many other, NCDs, the challenge is also that it's not just older people, which is the kind of profile you see in much of the Western world, for instance. But in India, you have younger people, who are being affected by these issues. So that is really something which is quite, a differentiating factor for us. So we need to, kind of come in and intervene at much earlier stages, in that sense. And we also have larger numbers, therefore, to deal with. And of course, rightly, a lot of inequity, in terms of the health system, different states, different districts, even. So I think clearly one of the priorities has been, and Dr. Kocher, spoke about it, that it's not just increasing the number of stroke centers, but also making sure that the quality of stroke care guidelines, protocols, these are, maintained and adhered to, because, you can have as many centers you want, but if we're not following the requisite protocols, then, or, the standards, then it's obviously problematic. So that is obviously one set of, interventions that we are focused on. The other, of course, is, addressing this inequity, right? So rural, urban, private, hospitals versus government hospitals. A lot of the, stroke units in the past, and of course we've made progress over the years, but we definitely need to do more, because a lot of these stroke units have been in the private hospitals, but we need to ensure that equally in the government facilities, and especially in the smaller, tier 2, tier 3 centers, we have, these services available, and with the requisite quality. I think so. And then I think, in terms of the human resource issue, I think that is also something that we're really looking to tackle. And when I say human resource, I don't just mean, at the bigger hospitals. I mean, that is one thing, but more so at the smaller, health centers, say the health and wellness centers, or other primary care level centers. At least the personnel there have to, have the ability and the training to impart, knowledge about these, like we said, the stroke symptoms. There can be a wide array of symptoms. They can be, sometimes they can feel a bit, non-specific, much unlike a heart attack, which could in some ways be easier for somebody to identify. So, even if I'm coming to a health and wellness center, the personnel there should be aware. They should be able to educate me, and they should at least be able to pick up that, I think what you're suffering from is something serious, and, you need to immediately go to such and such place. So I think healthcare personnel, across levels, need to be at least educated, sensitized, even if, they are not the ones who are necessarily handling it, but they certainly need to be aware. So I think that is another big focus for us. And just another aspect I'll, quickly touch on, which is that, the time sensitive treatments, like we've been talking, the clot bursting injections or thrombolysis, and the clot retrieving treatment, the thrombectomy, they've been expensive, unaffordable to many patients. It's and so the government of India, they included, stroke care packages, so including thrombolysis, stroke unit care, thrombectomy, in Ayushman Bharat. So that was something which was done because, so that the treatments are not expensive or unaffordable. So that is again something that we've tried to do to address the treatment part of things. But I think a lot of focus is definitely going on the prevention, the early response. We're trying to see how we can integrate technology. When we've had so many tele ICUs, during the COVID time, we can certainly use technology even in issues like this. So I think we're trying to see how we can integrate all of that. And we're also focusing a lot on the prevention, lifestyle part. I think that because you asked about public health, so I think that is something we are doing, because like I said, in India, younger people are getting it. We can't afford to be complacent. We can't say, okay, this is only a problem that affects much older people. Much younger people in our country are getting it. So we really need to focus on prevention, lifestyle from very early stages. So that is also a paradigm that we're trying to bring into the policy discourse.
Thank you so much, Urvasi. I think that's all these areas are very important, and it's good to hear that apart from taking some concrete steps like inclusion of stroke care in Ayushman Bharat, and also trying to increase the capacity of these health and wellness system, which itself is an important infrastructure being built by the government. Utilizing or using or leveraging technology, which is definitely going to be an important area. So I think these are all important steps being taken. Dr. Suri, from the India's context, so we have kind of a substantial progress being made, at least. I have been following this area for last almost 4 years, when we started Stroke Summit and initiated the whole this kind of campaign, or strengthen the campaign of making India stroke ready. Now we have around 400 centers, which Dr. Pandian also talked about, being quite robust, and having that the entire flow in place. And then we have a strong work being put forward by NABH kind of institutions, which are trying to add more such efficient centers. And then the government at the other side, which is trying to bring in all possible public health interventions also. As a president of Indian Stroke Association, what are the key areas now you see where we need to now move forward to cover up as much as possible, and as quickly, because as the number says, that we lose a lot of life or the productivity in the case of disability to stroke. What are a few maybe 3-4 points which you feel which we need to now as a government? So we have Niti Aayog, is Urvasi Prasad here, Dr. Kocher from NABH, and then we have even the World Stroke Association president-elect here. What are the 3-4 points which you feel are going to be important for all of them to collaborate and achieve that?
See, I think we have to be very, very clear that prevention is better than cure. And for a country where blood pressure, diabetes, obesity, smoking, tobacco chewing is also prevalent, so I think prevention is something that is something very important, and that I think the government, the private setup, all the doctors, public awareness programs should go on telling people how to prevent stroke. In fact, the catch line should be that 80% of strokes are preventable. And therefore, it is very important to have lifestyle measures. If you have diabetes, a lot of people understand that they have diabetes only when they have the first stroke. They'll find out they have a 500 blood sugar, and they never knew that they were diabetic. So I think this primary prevention, where caring for diabetes, identifying diabetes, caring for blood pressure, these are the two big killers. Then smoking and tobacco chewing, which is again very, very prevalent in India. That awareness should be there. Then obesity, in certain food fads that one has, the kind of food one is eating. So one should be aware of, what the what the body mass index should be. We should keep it less than 25. We should have, regular exercises. So prevention of sedentary. So prevention, I think, is one aspect which government as well as private sector, doctors, the press, they should all be putting in. So I think prevention. Second, awareness how to identify stroke. I think that is something which is a real important thing. How to identify immediately what a stroke is, and then what to do at that time, and where to reach, because the initial period should not be lost. And then for sufferers who have suffered, the third aspect then we will be to put them into a good rehab program, to reintegrate their life, to get them back with good occupational therapy and good rehab. So I think these are the big three pillars: prevention, acute treatment, and then rehabilitation. And then one can go into these, from the big pillars, one can go into the smaller and finer aspects of each. But one has to work around these three pillars. Prevention, I think, should be the first and foremost, because that would affect the entire population. So I think that prevention should be very important. Acute treatment, how we can spread it across, not only in the metropolitan, but also into the second-tier cities and also up to the village. That, I think, is the major task. You may have awareness in a village, but the nearest hospital which is stroke ready may be 4 hours away, and there is no transport to reach. So I think acute, how to get the acute treatment, and then rehabilitation. There should be facilities both in government and private. India is really lacking on the rehabilitative facilities. So, government set up, because one cannot afford, good rehabilitation, robotic hands and other things. Everybody can't afford. So there should be a good rehabilitation process, both in government and private setup. I think these are the big three pillars, and then one can work around, into the smaller aspects or the finer aspects of that.
Absolutely, Dr. Suri. I think very important points. And they are not, prevention is something which is, if it become a part of life, it will not only help people prevent one disease, but maybe multiple, and most of those NCTs are, in a way, having the same.
One could always say that, you do these lifestyle measures, you protect stroke, and in the bonus, you also protect a cardiac disease. So you get one with one free.
Yes.
So lifestyle diseases will save you from a lot of medical illnesses.
Yes.
It's the big five.
Dr. Menon, would you like to add any specific point, from the same perspective? What are the next important steps when it comes to making India stroke ready, and what can all kind of stakeholders collaborate for?
Thank you. I would just like to add something, as Dr. Bihar just said that, Urvashi, doctor has just said that we are having a young population which is getting into the stroke spectrum now. And most of the time, again, apart from the awareness of the diseases symptoms, it is not still entered into the public domain that young people can also have stroke. So it is still continuing to be an age-limited disease. So over 65 can have stroke. If the person is 35 or 40, they cannot have stroke. So at least a message should pass on to that you can have a young stroke. Young people can also have diseases which can have those lifestyle-related diseases. And when all of our messages are going across, I feel that all of my other panelists will surely agree to me that reaching the hospital is time bound. So I suppose the ambulance services should be highlighted, that use the ambulance to reach the hospital. And we have done a study, and we have found that people who use the ambulance, irrespective of whether the patient party knew that whether it was a stroke or a heart attack, they reach the exact hospital, because it is always easier for us to spread the awareness across the transport facilities because they are a focused crowd. So if I have 108, I have 104 across, and I can tell them that these are the stroke ready hospitals, and if the patient has got these symptoms, they can go off there. So one is our ground staff getting more and more aware. Our community health workers, we have a lot of them now. Our social workers, Anganwadi, ASHA workers, where they should be primed, one, for prevention, and to take it forward, having a data of the people that they should be told that these medicines have to be taken. Usually they are seen that they have been detected to be hypertensive, diabetic, or XYZ NCD disease, but then they are not continuing on the treatment. And that's a secondary treatment gap, which is extremely rampant in our population, knowing about the disease, but they're not taking the treatment forward. So small lacunas are there. But all of these lacunas, I feel, if there is a flow chart across to the public domain, to the healthcare worker domain, and to the auxiliary workers domain, if that is spread across, then we can target our population and reach forward.
Thank you, Dr. Menon. I'm sure there's a very important point. Dr. Pandian, we have just 4 minutes left, so we'll try to take once more Dr. Pandian and Dr. Kochar and probably Urvasiji also. Dr. Pandian, what are the some of the steps from your point of view, and especially considering the best practices globally, and because now, as your role in the global stroke management, what do you see as the most important kind of initiatives now need to be taken?
Yeah, I think from the global perspective, from World Stroke Organization, we have this implementation task force with representation from all across the world. And our primary objective is to implement stroke care at all levels of healthcare facility, like whether it could be a health and wellness center from the India, or secondary level hospital, like district level hospital and tertiary care hospital. So we try to work with country leads, the country champions, and the various national stroke organizations, so that this is uniformly done all across the world, particularly in low and middle income countries. So we have some success stories from Africa, from India, and then some countries in Southeast Asia. I'm doing with the World Health Organization, Southeast Asian Regional Office, along with the WHO, to develop stroke care in 11 countries in the CRO region. And so our primary objective now is the next 4 years, we should work on this implementation part. Second is the quality, that is a certification. That is where we have signed an MOU with NABH, and we have come up with these standards. Once it is rolled out in India, because NABH has footfall in other countries, so our plan is to go to the other countries. The objective now is the next 4 years, we should work on this certification program. Second is implemented the quality, that is a certification. Recently in the that is where minority in the Middle East and North Africa region. We have and slowly there are many countries from Southeast Asia that are interested. So these are the 2 ways that we are planning to focus on the next 4 years to implement stroke care across the world.
Thank you so much, Dr. Pandian. I think this journey which you have started with NABH also, this is definitely going to help us in bridging these gaps, and also maybe the same can be replicated by NABH in the other countries also. That's wonderful to hear. Dr. Kochar, the path seems to be quite clear for NABH. Once you have already developed those standards. But how do you see it, getting a little bit more expanded in terms of, taking it to the level of almost 18,000 hospitals you are touching to, and also I think a lot of them in rural setup also. How all of them can become the part of this at least standardized referral system, or at least in delivering the last mile awareness about these critical diseases which we are trying to kind of plug at one end.
Yeah, thank you, Kamalji. We would like to invite everyone to make use of these certification standards. There are lots of learnings there. just like this has been a wonderful session with lots of learning for personally me also, I would like to invite everyone to download these standards. They are free of charge, and make use of them. There are checklists there. There are basic learnings which are very equivalent, and they suit all maturity level of hospitals. Secondly, I would like to request all, like Dr. Suri is there, and all resource people, all stalwarts who have developed certain resource material, and they wish them to be disseminated to our partner hospitals. Please use NABH platform for this mission. We touch these hospitals, and these hospitals nowadays in tier 2, tier 3 cities, they're very aware that post-COVID, they wish to improve themselves. But they need authentic, evidence-based, simple, plain English, in vernacular research material, resource material. If you feel that some good idea should be disseminated, because that's what it is. We are as strong as the weakest link in the chain, and until something reaches the last in the line, our herd immunity is not going to improve. So we cannot just get away by creating islands of excellence. So no doubt we are working towards that, and we are very proud of our 450 stroke centers, and we really hope that we'll add much more to these numbers. But we must take this mission to the last in the line, and that's extremely important because and we all can do it. I mean, there are so many organizations. There's Indian Stroke Association. There's WSO, which is steadily working in so many countries. And thank you, Dr. Jairaj, Dr. Shailaja, Dr. Padma, all of them who came together to draft and vet and multiple iterations finalize this checklist. So I truly believe we can do it jointly. It's a complex thing, but everyone's input is extremely important for that. Thank you for the opportunity.
But wonderful, Dr. Kochhar. Urvashi ji, would you like to add something on this? And maybe you may like to add a little bit more on the technology, how it can play the role in overall stroke prevention as well as management.
So, Kamalji, I think all the major points have been made. But again, I would of course also agree with the the need for the emphasis on prevention, as I was also saying in my initial remarks, that that's really the spectrum, that end of the spectrum that we are focusing on, because we are too large a country, and the numbers are too large to afford to keep waiting till people actually develop symptoms, or people actually reach advanced stages of these illnesses. So I think definitely there's a lot of emphasis on prevention, and also integration of Ayush, especially yoga, relation to brain health, and a lot of those kind of aspects also that we are looking at, and we're also trying to build an evidence base around it, because often, of course, when we talk about Ayush integration, there's always a question of where's the evidence. So we're also trying to build the evidence base around some of these things, and see how we can integrate that, and then of course technology. I think especially in our smaller centers, where you might not have, or in our very rural, remote areas where you still might not have those kind of skilled personnel available, and we know that we have a huge shortage of still in many parts of the country, a shortage of these kind of skilled specialists. So there, I think technology, especially, we are thinking, and we're trying to deploy. We started doing pilots also in different states across the country to see that how technology can help, address that shortage of that, skilled personnel in those centers, and make sure that the specialist advice can still reach people who are at these centers, and provide support to patients who do end up there. So I think that is really how we are thinking of using technology in this context. But also I think Ayush is something that we are really focusing on, and like I said, trying to build the evidence base around it.
Great. Thank you so much, Urvashi. So I think most of our experts have made very clear points about how we can both prevent and manage stroke, and thus reduce the burden of stroke and its the fatality and the death and disability caused by it. And the most important, I think, which is coming out, I'll refrain from the a long conclusion, but I think for the layman, for the people, the important message is that your health is in your command, and a lot of steps you need to take when it comes to prevention of all diseases, including stroke as well. So with this message, I think we rededicate our efforts, our resolve, and towards making India stroke ready, and also reducing the burden of a stroke, which make people suffer in our nation. So thank you so much for joining on this the inaugural session of Stroke Summit this morning. The next panel we already can see here, and we are going to have another powerful session, and my colleague Asaudi Sawant will be hosting the same. So over to you, Asaudi, and thank you so much all our experts today for joining us. Thank you.
Thank you.
So
Thank you
much,
very much.
Mr. Kamal. Thank you so much to all the participants of panel 1. We will be starting with the second panel discussion right away. So I welcome all the participants of panel 2 for joining us. Thank you so much for joining. Let us start with this discussion. We are commemorating the World Stroke Awareness Day for the 29th of October, and hence we are doing the 4th edition of Stroke Summit, an initiative of Integrated Health and Wellbeing Council for acting fast for a stroke-ready India. This discussion today is a very insightful discussion on the topic of stroke, and the topic for this discussion is precisely on adverting disabilities and long-term impacts of ischemic stroke, for which we have an eminent set of panelists here with us today. I welcome Dr. P.N. Shelja, Professor and Head of Neurology in charge, Comprehensive Stroke Care Program, Sri Chitra Tirunal Institute for Medical Sciences and Technology. Ma'am, thank you so much for joining us. I welcome Dr. Biplab Das, who is Director and Senior Consultant of Neurology and Interventional Neurology at Narayana Super Speciality Hospital, Gurugram, Delhi NCR. So thank you so much for joining. We welcome Dr. Shirish Hastak, who is Regional Director for Neurology, Stroke and Neurocritical Care with Global Hospitals, Mumbai. So thank you so much for joining. We also welcome Dr. Madhuri Behari, who is Consultant of Neurology with Fortis Flight Lieutenant Rajan Hospital. Ma'am, thank you so much for joining us. We also welcome Dr. D.S. Gupta, who is Senior Consultant and Stroke Unit Head with District Hospital, Jhansi. Thank you so much for joining. With our panelists all introduced for this channel, for this session, the focus of the session would be to examine the impact of stroke on the patients. The session will also highlight the role of mechanical thrombectomy to treat patients of acute ischemic stroke, and if it is possible, to reverse the damage to some extent or in full with the help of mechanical thrombectomy. The discussion will also examine the impact of antithrombotic drugs in averting the long-term impacts of stroke and ensuring quality of life for patients. So I welcome you all. Thank you so much for joining us. Let us start with this discussion. So as the topic of the discussion is on averting disabilities and long-term impact of ischemic stroke, but to our audience that has started watching us just now, just to set a brief context, my first question to Dr. P.N. Shelja is, ma'am, can you please help us understand what is the difference between a stroke of a heart and stroke of a brain? I know this is a very basic level question, but as our audience is a mixed audience from both medical and non-medical backgrounds, so it will help them understand what this is. If you can also highlight some basic signs and symptoms so that they are able to detect that this is, a stroke that need to be acted faster. Over to you. Ma'am, can you please unmute yourself?
Thank you, Sam, for this invitation to be in this panel. So this is one of the basic questions, but I think it is still very important because the awareness of stroke in the public and also even among the allied health professionals also is not very good. If you look at the stroke symptoms, the most important thing is the public or anybody should understand is heart attack and brain attack is totally different because every time it is always put together. So heart attack means where there is a blood flow disruption of the vessels of the heart, which produces a heart attack or a myocardial infarction. Compared to that, a brain attack is what we mean as stroke. For stroke, there are two types of stroke. One is the ischemic stroke, where a major blood vessel or even a smaller blood vessel in the brain gets blocked by a clot, which may be formed in situ in the vessel itself, or maybe a clot is coming from somewhere else. It may be from the heart or other peripheral region and blocking the blood vessel in the brain. This is what is called as ischemic stroke. So because of the block, what will happen is the area which is being supplied by the blood vessel will get infarcted. That means the brain cells die. And because of that, whatever function is being sustained by that brain cells will produce some disability to the patient in the form of weakness or difficulty in speaking, or if it is a major stroke, it can even produce a significant disability in the form of loss of consciousness and other aspects. Second type of stroke is the hemorrhagic stroke, where there is a rupture of the blood vessel producing a bleeding into the brain, which is called hemorrhagic stroke. If you look at overall these strokes, about 80% of these strokes are usually ischemic in origin, where you have a blockage of the blood vessel, and about 20 to 30% will be hemorrhagic stroke, where the blood vessel bursts. Most of the time it is because of hypertension, but there are other causes like vascular malformations like aneurysm or an arteriovenous malformation or vasculitis. All these produces bleeding into the brain. If you look at the symptoms of this stroke, the commonest way to identify for the public is the FAST, which we use, whereby we can recognize the signs of the stroke. The most important presentation is you develop weakness of one half of the body. It can be a right side or the left side, or you can have a sudden difficulty in speaking. You may not be able to understand, or you may not be able to speak. A patient can have a sudden unexplained headache, a sudden loss of consciousness, or they may be developing a sudden difficulty in walking because of unsteadiness of gait. So these are all the common symptoms, but everything comes very fast. It is within minutes to seconds. So anything which comes abruptly and you have any of these symptoms, you have to suspect it is stroke and you need to take the patient to a stroke-ready hospital.
Thank you so much, ma'am, for so nicely explaining us all different aspects around stroke. My next question is to Dr. Satish. Sir, as an expert in stroke prevention, what measures and strategies can be implemented alongside mechanical thrombectomy to reduce the risk of current ischemic strokes for patients? If you can also help us understand the various other disabilities that are caused due to stroke, not just this one.
Yeah, so it's vital information. The stroke, the major mantra in the management of acute ischemic stroke is two concepts, which is one is time is brain, where immediately after the onset of stroke, you should not waste time because the disability will be more, even the mortality is higher. The second mantra is tissue clock, where even outside the initial 4.5 hours of window period, for say example 6 hours up to 9 hours, for that matter even 24 hours in some such conditions, where the tissue clock, where you decide whether how much is the salvageable tissue around the occluded blood vessels. So if you can able to recanalize the blood flow by doing some procedures called mechanical thrombectomy, so there is a chance of reperfusion, so that the blood vessels, blocked blood vessels got opened, and then the final outcome of volume of stroke is reduced, and henceforth the symptom, signs and the disability. So mechanical thrombectomy is a good additional armamentarium in the last 8 years after the positive trials in 2015, which is very important for conditions like large vessel occlusion, where there is an important branch or important main vessels of the brain blood flow is occluded. So the second question is, what is the disability due to stroke, right? So said that we will all talk about treatment in the acute window period for both thrombolytic therapy as well as thrombectomy. But the disability is more crucial. The disability is not always physical. Once a heart attack patient can go back to his occupation, he can be economically productive, he can lead a normal life with some stents and some antiplatelets on. But once crippled with stroke, with paralysis, with motor deficits, not only that, some people develop cognitive deficits. They may not get employment also, and sometimes they may lose their family because of complications. Some gets divorced. There is no active social life because they are crippled in the wheelchair. They couldn't speak. So it has a lot of psychosocial, emotional disability. More often, the disabilities can be, this is the most commonest disability than orthopedics and other things. So this can be taken care of by a comprehensive stroke team, not only in the acute treatment and the post-stroke care support group, where we talk about physiotherapy, occupational therapy, speech therapy, and vocational training, as well as psychosocial impacts after the stroke. And there are ways to do that. I think we can discuss in further questions. Thank you.
Thank you so much for so nicely explaining, Dr. Satish. My next question is to Dr. Shirish Hastap. Sir, from a neurocritical care perspective, what are the key considerations that are looked at while managing patients post, having these disability issues post-stroke? Or if we are specifically talking about post-mechanical thrombectomy, to minimize the risk of, any other complications that they might have.
Yes, after an acute stroke, and of course, it is little different if the stroke is ischemic or if it's an intracerebral hemorrhage or if it's a subarachnoid hemorrhage, because one must understand that there are actually three types of strokes, so to say. So if you're talking about ischemic strokes first, which is the commonest type of stroke, so we're talking about ischemic strokes, then of course, from the neurocritical care perspective, of course, as Dr. Satish has already said, the IV thrombolysis and the mechanical clot retrieval. So the IV thrombolysis within 4.5 hours and the mechanical clot retrieval within 24 hours. Of course, there has to be a large vessel occlusion for mechanical clot retrieval. And so once this is done, then the neurocritical care perspective comes in, because I would consider the acute treatment as emergency treatment, and then the further 24 hours treatment as the neurocritical care treatment. So in the neurocritical care treatment, one has to worry, and we usually counsel the patient's relatives with this idea that just because we have given the thrombolytic agent or we have done mechanical thrombectomy, it doesn't mean that the patient is going to recover tomorrow, or they think that it's tomorrow or day after that the patient is going to recover, now that you have given the thrombolysis or you have done the mechanical clot retrieval. So it's very important to explain to them that the risk of complications in stroke exists, and this risk depends on how large is if you're talking about is infarct or the blood vessel block, how large is the infarct, and what was the time that we lost before the patient came in, and what was the procedure that we did. So there is a risk, and this is the neurocritical care idea, that you can bleed if you do either an intravenous thrombolysis or do a mechanical clot retrieval. Having said this, of course, the chances of recovery by doing these procedures is much higher and the risk is much lower. So you have to look at the risk-benefit ratio. So the benefit is much higher, the risk is lower, so you do that. But once you do it, the risk of complications exists. So the first complication we worry about is bleeding in the brain after we do either the IV thrombolysis or the mechanical clot retrieval. And this can lead to brain swelling and, of course, alter consciousness of the patient. We may have to evacuate these or treat these with various medicines to stop the bleeding in different ways. The other thing that can develop is swelling of the brain without bleeding. So the brain can swell up because of of the infarct or the damage itself. And this swelling usually happens 24, 48 hours or even up to 72 hours after the stroke. A third thing that can happen is you can get seizures or fits after the stroke. And so again, this is a complication which comes under the neurocritical care part. And of course, if the stroke is in the brain stem or in this area which is very critical for your respiration or for your functioning of your heart, you can have a patient who will need a ventilator, and then the complications of ventilator. So you have to sort of counsel patients that it's not all over as soon as you thrombolize or as soon as you do mechanical clot retrieval. This is the beginning of the battle, and the battle can extend up to 1 week, 2 weeks, 3 weeks, depending on how bad was the initial stroke. So I always tell my patients that, please understand that whatever outcome issues you read are actually 3 months outcome issues. They're not, because the problem is that patients feel that it's not 3 hours, but it may be 3 days outcome we are talking about. But we are not talking about 3 days, we're talking about 3 months. So very important to counsel them that we do have to go through this little difficult period initially. Of course, if the stroke is very mild, if it's a TIA, that doesn't exist. But in a moderate or severe stroke, especially in the severe stroke, we need to, and even in the moderate stroke, we need to counsel them about the risk of complications, about the risk of deterioration, and about the risk of proper critical care, and go into a proper hospital for this critical care. So I think I always counsel my patients that strokes can deteriorate, they can be complications, and brain swelling, intracerebral hemorrhage, seizures, even going on ventilators can happen. And counseling them on day one is very critical in terms of stroke. So that's what I would say about these neurocritical care complications.
Thank you so much, Dr. Shirish. And sir, not just counseling to the patients, but also their family members, because most of the times families are also in the promotion ki ek cheez ye procedure ho gaya, and now we can, feed them any kind of food that they were having, and any kind of other lifestyle habits that they were having, and it's all sorted. So many times families are also in that sort of promotion. They also need to be counseled that the recovery is also a long-term process, and you have to take precautions in many different aspects of the patient's life. So my next question
Absolutely
is,
true. I think I completely agree with you that it's the relatives of the patient, and and sometimes because these are modern times, we do record this as well, so that they have been informed that these are the things that can happen, and the family members are very critical, as you correctly said, because the patient may not be in a position to understand. So I think every family member or the closest family members must be counseled properly about the neurocritical care complications. Thank you.
Sir. Thank you so much. So my next question is to Dr. Biplab Das. Sir, as Dr. Shirish was explaining, that there are different types of strokes. So 3 different types of strokes that he mentioned, and also depending on if it's a moderate level or severe level. So can you please explain us and our audience who do not know much about this topic, that what are the differences between these 3 different types of strokes, and how it is categorized into moderate or severe? What are the protocols?
Yeah. Thank you very much, first of all, for everyone. So as you say, the stroke, before that, I just want to highlight a stroke is something, which is a time-dependent medical and surgical emergency. There are few, and if I remember correctly, like a stroke and then cardiac attack, acute coronary syndrome, which is time-dependent medical emergency. So it is an emergency of the emergencies, right? And grossly, we divide a stroke is one is ischemic as because of clot, and other is because of hemorrhage. So hemorrhage can be either subarachnoid hemorrhage, or hemorrhage can be intracerebral hemorrhage itself, right? So whatever we are talking or emphasizing more is an ischemic stroke. That is a stroke because of clot. So clot is going into the brain and blocking one artery, which may be a small artery, which may be a large artery. Okay, and that give rise to symptoms of a stroke, paralytic attack. Similarly, these similar symptoms can happen because of rupture of blood vessels in the brain, which can give rise to bleeding in the brain parenchyma, like it may be because of hypertension or some arteriovenous malformation sort of things. Or it can be subarachnoid hemorrhage. So subarachnoid hemorrhage is a bleeding where the blood is accumulated over the surface of the brain. Okay, that's called subarachnoid space, right? And this usually happens because of, if it is not because of trauma, say for somebody who is having road traffic accident and sort of things, can have subarachnoid hemorrhage. So if you exclude traumatic cause, the next most common cause is because of brain aneurysm. So it's like a ballooning of brain artery and which ruptures, which give rise to bleeding in the subarachnoid space. So primarily I would like to talk right now more into ischemic stroke, because that is more common, like 70-80%, as Dr. Salja was also talking about, no? So 70-80%. So if you move more towards eastern of India, we see more hemorrhagic stroke, but saying so, it does not mean that the hemorrhagic strokes outnumbers ischemic stroke. So ischemic stroke is always much more common. It's maybe 75-85 sort of things. So ischemic stroke, because of clot in the brain, time is very, very crucial. Time is brain. Coming to the importance of treatment of mechanical thrombectomy, right? So there are two modalities of treatment which is being given all over the world, which is in highest level of evidence, class 1A evidence. One is giving an injection so that we can dissolve the clot, inside there is a clot busting medicine. And another is supposedly the clot burden is high, right? So there is a large clot which is there inside the brain. So giving that injection may not be sufficient to dissolve the clot. So that's why we need to have we need to take out the clot. After all, the main target is, we take out the clot and the reperfusion, the blood should be restored into the brain before the damage is permanent. And that's how it is a time-dependent fact. So the mechanical thrombectomy, which is being performed, which is over the years, like, from 2015 onwards, there are robust data has come, which is a highest level of medical evidence in the form of RCT, multi-center RCT. And that is, having class 1 evidence, where we found that if you take out the clot within the golden hours and restore the blood supply to the brain, the outcome is wonderful. And the outcome, as it has been mentioned earlier also, we not day 1 or day 2 post-procedure, we see day 90 to see exactly what is the outcome. And there are lots of ups and downs happens during the first week time. It depends upon how of the brain involved, how much we could save. Mechanical thrombectomy is such a crucial part because earlier we used to say time is brain, right? Because it's a time-dependent emergency, right? So earlier the golden hours for thrombolysis is like 4.5 hours. Now over the years, we have found the data has established that everybody, the brain is different. So my circulations, there are two arteries going from anterior side, and from the back side, there are two arteries, and they are going inside and then connect with each other. Connections for everybody is different. So that's how we in medical say it is a collateral circulation. So that collateral circulations is very, very crucial. How much, it's not the time. Somebody's coming after 4.5 hours, still we see that lots of area brain is not damaged. It's because the collateral supply. Whereas somebody's coming within the 2.5 hours of time, is still, damage part is high. It all depends how is the circulation inside the brain. So that's how we are moving from time to tissue now. And that's how now even patients who are having large vessel occlusion stroke, we can perform mechanical thrombectomy beyond up to 24 hours, which is established now. Because we need to see the brain, how much area of the brain is damaged and how much area we can save, right? So this is regarding ischemic stroke, where there is a significant role of neurointervention. And we do mechanical thrombectomy in cases who are having large vessel occlusions. Coming to points of aneurysm rupture, so that is giving rise to subarachnoid hemorrhage. And we have a very advanced, device now, or hardware available, where very small to small aneurysm, which can be treated very effectively with endovascular procedure. Endovascular procedure means we reach into the brain not by opening, we reach into the brain by using through vessels, either through the radial artery or femoral artery or direct puncture here in the carotid. So we reach into the brain and seal that aneurysm. So I'm not going in detail what are the devices being used for aneurysm and all, because we are mainly talking about ischemic stroke here. So I think that's how the role of mechanical thrombectomy is very, very crucial now for patients who are having a stroke, especially ischemic stroke. Thank you. Over to you.
Thank you so much, Dr. Biplab. My next question is to Dr. D.S. Gupta. Sir, you have been patiently listening to the conversation that is going on. We are very curious to know that, is there some kind of population that is more susceptible to getting stroke? Is there something like that? Or if not, can you also please elaborate on the risk factors apart from injuries? So apart from trauma cases, if there are any other risk factors also that might lead to development of stroke.
Thank you, everyone, dear seniors and dear colleagues and all. Main thing is that in these cases of brain stroke, we have a fast means the symptoms of stroke, everybody has to be generalized. Even media and other persons, family members or other persons should know that what is the meaning of stroke and its implications and symptoms the public has. If the persons or family members knows that a patient is having the stroke, you can go to the stroke ready hospitals. As questions is that what are the risk factors, as everybody is knowing of this there is the hypertension, diabetes, cholesterol, triglycerides levels. These are the main risk factors by which the patient is having stroke. Most of the patients are having stroke. So, in the public, most of the persons should be examined for the blood pressure, blood sugar, and triglycerides and cholesterol level. So the risk factors can be minimized. And involvement of the not only of the public but press media, they are very important to know that these are the symptoms of the stroke and these are the symptoms for the risk factors by which stroke can be minimized. Because after the stroke, as most of the persons and panelists have said, that there are the risk for the developing afterwards, after the stroke. So the management of the post-stroke seizures, as you know, in around 20% of cases, and after the thrombolysis, there is also many cases of the bleeding. So there are the many complications in that cases also. We have made the our hospital stroke ready hospital and telling most of the public by the media that they knows that that hospital is the stroke ready hospitals and these are the risk factors in the main public and can be minimized and patient that time is the brain. Earlier was very significant. Now it is also that time is the brain. There is no doubt about it. Even other that mechanical thrombectomy has been come in the picture also. But time is the brain. It will remain always in the gold standard that time is the brain. Everybody should know the fast means face any paralysis of the face, drooping of the mouth and eye muscles, slurred speech, and likewise the these very symptoms which the public should know that he is having the paralysis. Most of the persons in the public, they don't know the exact that person is having the stroke or not. So awareness is the most important things that public should be know, and our duty of our medical person's duty is to know to advertise that these patients might have the stroke and already respecters, if they should be removed or they should be treated in time so so the stroke will be minimized. And after the post stroke seizures there may be there are many drugs and they should be treated accordingly and their complications should be also treated accordingly, so the burden on the society of the stroke will be minimal, because burden is the most important. Even MI patients, they or other patients may die after sometimes family members will forget. But if the person has developed the paralysis in the family, it will be very troublesome for the family as well as by the society, by the government, and overall for the country. So we have to prevent stroke as early as possible to be treated, and the risk factors to be should be dealt with. That is my ultimate
Message.
conclusion to tell all one.
Thank you so much, sir, for sharing your inputs and your message of making stroke care as fast as possible. So my next question is to Dr. Madhuri. Ma'am, do we
for arranging this meeting? My predecessors have talked about the symptoms and the management and the risk factors. And so we have a group of intravascular and clot bursting devices and medicines. Because of these, the number of people who survive are much higher than they were before. So earlier we used to have about 25% used to die within first week or 10 days. And only 10% would recover fully. And 40% would be left with a moderate to severe disability. And a small percent, like 25%, would be left with some impairment. They could still work. So this leaves a very good chunk of people who need care even afterwards. And this disability may be in the form of speech, cognition, motor, sensory, or even psychological, like depression is very high. Almost 50 to 70% of patients get depression. And epilepsy and seizures can occur in these patients also. So apart from these known things, there are two other major things like depression and epilepsy, which are also very important for these patients. And these need to be addressed too. The first thing that I insist on my patients who come for acute management is that I start physiotherapy rehabilitation right from day one. It's not that you are undergoing thrombolysis, so you cannot have any exercises. So exercises are started right from the beginning. As we all know, any disease, prevention is better than cure. So earlier also the patient should be doing, every person should be encouraged to do physiotherapy, yoga and such things so that they are physically fit. But afterwards, when they have stroke, I make it a point to start the rehabilitation process right from day one, and that should proceed. And the rehabilitation is not just strength of the muscles, but also the usefulness of the fine finger movements. For example, they should be able to hold pen and be able to write.
Hello. I believe, yes, I believe there is some network. Yes, ma'am, please continue. We lost you for a little bit in between.
Yeah, I'm sorry about that. So it's not just the power of the big muscles. I also will insist that the small muscles are very important for intricate working. For example, to be able to hold a pen, to be able to button your shirt, to be able to zip or unzip the cloth, the dress that you're wearing, and also to turn the pages like that. Sometimes the fingers are not able to turn the pages. So how do you read? Most people read books even now, or not. If you're not reading books, you are counting the currency bills. So that becomes difficult to do with the hand. So all those things, fine activity have to be started right from beginning, day one. And I make sure very, very, very well that it is done. And these can be combined with playful activities. Like if you want to test the balance or improve the balance, you can play ball throwing, ball holding. That's very important. And that adds a playful activity to the patient. So they can play ball, throw the ball into the basket, games like that. So I make it a very active and very interesting activity for the patient so that they don't say ki, "Arey, mere ko itna thaka diya," and such things. They enjoy it.
Thank you so much, ma'am, for sharing very vital tips. And I'm sure all the other clinicians are also employing them. It is good for the audience to be informed that these are the recovery procedures that are employed post the treatment. So my next question is to Dr. Shailja. Ma'am, we are very curious to know a few different aspects, starting from if there are any, gaps in the care system that you experience as India is such a large country and the number of people suffering from stroke is also very high. But there is a limit to the amount of specialists that we have in the country even now. So how do we manage these things? We are putting efforts to make more and more hospitals stroke ready. So can you please also inform us what is the meaning of a stroke ready hospital? What are special infrastructure or special areas that are need to be prioritized in making one hospital a stroke ready hospital? So 2 parts to the question.
So thank you. I think it's a most important question which you have asked is with regard to the gaps in the stroke care in India. As we all know from the global burden of disease study, stroke has jumped from the 11th for the disability life years. It has come to the 6th important cause of disability. But most important is that India, with this huge population, is not ready to take up this huge burden. And we know that 80% of this burden is in the low and middle income countries. And we have the disease in the patients 10 years younger than the age at which the developed countries are having the stroke. Our mean age is around 55 to 58 to 60 years. If you look at the gaps, you can say that it can be at all levels. The first most important gap is with regard to the awareness, the public awareness of the disease. I think if you look at the public awareness, it is almost the same in both the developed and the developing countries, because we still know that even in the best comprehensive stroke care centers, even abroad, we find that not more than 20 to 25% of the patients receive revascularization therapies. So we need to definitely have awareness activities at all levels, starting from the doctors to the public, and at all levels it is required. But one of the major gaps, I would say, which we were still not able to tackle is with regard to the EMS facility. What we mean as EMS facility is to have an emergency care system, which should be a universal national level system which needs to be developed. Currently, what we have is many of the corporate hospitals have got emergency systems, which is used partially. But unless we have it at a national level, because even in Kerala, we have got this 108, which is still functioning. But as you know, most of the 108 facilities are being used only for trauma and rarely for even heart attack, but never for stroke, because we have been involved in training them. And less than 5% of the patients with stroke are taken up by the EMS facilities. So unless the EMS facilities comes up, none of the stroke patients are going to be identified on time and they will reach the hospital. We ourselves did the inter-US registry, prospective registry of 2,066 patients identified from 5 comprehensive care centers, which involves our center, AIMS, CMC Ludhiana, NISAMS, and PGI. Only 3.5% of the patients came by the EMS system. So what is going to happen is that patients never get recognized and they reach on time. So I think at a national, I think it should come at a policy level. There should be a national system, just like is happening abroad as 911 or those kind of systems needs to come out. There are plans from the ICMR. There is going to be a major project which is going to start running, whereby probably the gaps will be identified. And it's not only for stroke, for all emergency systems, I think it is very, very important. Third, as you rightly pointed out, is to have stroke-ready hospitals. Recently, we did a geomapping study of looking at how many stroke centers. We still do not have a real mapping of how many stroke-ready hospitals or stroke units are available in the country. Recently, we did this study looking at as a part of the Mission Thrombectomy 2020 project. We looked at the geomapping of all the stroke centers and also the mechanical thrombectomy centers. We have not divided between primary stroke care units and comprehensive stroke care units, but we found that there are about 550 or so stroke units all over the country. And for one stroke unit for, I don't remember the exact number, for 2.7 million population. So which is such a small number of stroke units we have for the country. And if you look at the thrombectomy centers also, it is less than 300. So which cannot cater to the patients. And Biplab must also be remembering that when we did the Mission Thrombectomy initial project, we looked at all the centers to find out what is the number of mechanical thrombectomy which is happening in India. And it was less than 3,000 per year, where we need a minimum of more than 1 to 2 lakhs of thrombectomy to be done. So definitely there is a need to have more stroke units in the country. It is and one more important point is that almost more than 70% of the stroke units are currently in the private sector. So that needs to change. We need to have primary stroke care units in all the district hospitals, and all medical colleges should have stroke units to manage stroke. So stroke units and we need more comprehensive care centers with a hub and spoke model, so that the primary stroke care units are all linked to this comprehensive care centers, where the patients can be readily transferred after thrombolysis for mechanical thrombectomy. Next important area of gap is with regard to the rehabilitation facilities. In the gap, I would also like to add regarding the cost of the treatment. Even though we are talking a lot about mechanical thrombectomy, we know that it is a very expensive treatment. The current IHW Bharat gives 2.5 lakhs is the amount which is sanctioned, which is not viable for any of the corporate hospitals even developed. And Dr. Hastak, who is in one of the major hospitals, will agree that it is not viable for the hospital to take up these patients. And even in Sri Chitra, we are not able to take up these patients. So unless the cost packages increase, it is very unlikely it will be used by the corporate hospitals, unless the private hospitals also come in, and there should be a private public partnership. It is definitely not going to improve, but government is having a policy of planning to have the increase of the package to at least 3.5 lakhs. Hopefully it comes up, and there will be definitely a change in the systems of care with regard to mechanical thrombectomy. One other important area is with regard to the rehabilitation centers. I think this is one of the most lacking thing which is happening in India. If you look at the patients who are going to private hospitals, after that they come for regular therapy. The patient may be admitted in the hospital even for 2 to 3 weeks, and they get good rehabilitation, and the patient goes. But if you look at the real bulk of the population who are being treated from district hospitals or the government medical colleges, you find that none of these patients receive rehabilitation after they go out of the hospital, and most of these patients are sent out within the first 1 week or even 10 days. So unless we have rehabilitation centers just like in the developed countries, where after the immediate treatment and once the patient is stable, we should be able to shift these patients to rehabilitation centers, as has been rightly pointed out by Dr. Satish and Dr. Madhuri Bihari. I think we should have a very good comprehensive rehabilitation center. Dr. Hastak is one of the best rehabilitation centers in their hospital. Unless it is available to the real big bulk of the patients, we may be treating about 5 or 10% of the patients, which is not going to make any difference in the management of the patient. So we need to have more rehabilitation centers where comprehensive rehabilitation can be given. There is a lot of lack of speech therapist. There is no way you can have a speech therapist unless the patient is being treated in a private hospital where a speech therapist is available. So I think that is one of the major things. And one more area. So I'm just touching on all the areas where there can be gap. And last area I would say is secondary prevention and primary prevention. I'm not going to touch on primary prevention because it is a huge area, but coming to the stroke survivors and the secondary prevention, I think there is a big gap. Because recently we did a study in our own patients and found that the medication adherence, what I'm talking about is medication adherence with regard to the antiplatelet medication, with regard to antihypertensive, anti-diabetic, all. If you take all the medication adherence together, and this is an objectively done medication adherence of the stroke survivors, only 40% of the patients were adhering to medication. And each of us as clinicians regularly see patients coming back with a recurrent stroke after stopping their anticoagulation and antiplatelets. So this to happen in the community, we just recently looked at our own Trivandrum district and the Kollam district. We looked at our patients, why they are not having a very good secondary prevention strategy. That is one area where the policymakers needs to really work on. We, after our Kollam project, we have given a recommendation to the government too with regard to, because patients do not have facility to regularly go and check their blood pressure, blood sugar, everything. It is not available free. We talk about all the wellness centers and the primary health centers available. But when we went into the community, all the treatment is not free. And HbA1c is not free. A lipid profile is not free. So how do the patients do it? Second is with regard to the continuous availability of all these medications in the wellness centers. It is not regularly available. So because of financial reasons, because of reasons where the patients are not able to get the medicines regularly, secondary prevention strategy is significantly failing. And we know that after a stroke, about 5 to 15% of the patients will develop a recurrent stroke. So recurrent stroke is also a burden in the community. I think these are all in a nutshell. I'm sorry I took some amount of time, but I was just looking at all the barriers and telling about the areas where we need to really work on.
You were very aptly able to pinpoint all those areas that we have been talking about in the previous session as well, wherein we are seeing persistent gaps when it comes to the cost incurred, when it comes to the primary and secondary prevention, and all different areas that you touched, ma'am, are very vital. Thank you so much for bringing out them in such a nice summarized way. And I'm sure all the specialists that were listening also were agreeing. I could see Dr. Biplav and Dr. Shirish just agreeing to every point ma'am was saying, and me being enlightened. Ma'am, there is one point that we would want, but I would take the question from Dr. Shirish. Sir, what are your thoughts on the research around stroke that we have in this in the current times in India, and that too research specifically to the Indian population? What do you feel about the levels of research that India is currently executing around this aspect, and how much more is required, and what kinds of impacts would it create on the advancements in stroke care that we are anticipating in future?
Yes, I think a very important question, because I think over 35 years of stroke practice that I have done, I must congratulate Shailaja, Biplav, Satish, and the younger generation, Dr. Gupta. These younger generation people have really taken up the research to the next level. And of course, Jairaj Pandian for forming a proper consortiums. And, so I saw the Indian Stroke Association grow. I've been the third president of the Indian Stroke Association, but I saw it really grow with Shailaja and with Jairaj Pandian. I really saw it grow. It's great pride that I look at this association now, in terms of research, because they have really come together. And, when we started it with 20 or 30 neurologists, and now we are over 1,000 neurologists in the Indian Stroke Association. So, it has the Indian Stroke Association with Shailaja and Jairaj have really brought people together. I mean, and by bringing people together, they have formed teams, like she said, the thrombectomy 2020, and these ideas of forming teams internationally with people. So, the US or Canada and India. And Dr. Anish Singhal, of course, again, another person who is from India but went abroad, has formed teams with us. And I think I congratulate these people, for getting into research really earnestly and working on finding out where is India exactly. Because in the past, we would mostly go by the Western data and not have data for our own country. So I congratulate them for generating data for our own country. As Shailaja correctly said, if only 3% of people are using the 108 to bring patients into the hospital, I think it's a big issue to be sorted out. And so looking at the gaps, the research in the gaps, and not just the research in the non-gaps area. So research in the gaps is very critical. As she correctly pointed out, that getting only 40% of patients are sticking to the secondary prevention treatment. So those are the gaps. So really, I think we need to focus on research in the gaps. And in the past, we haven't done that. But in the last 10 years or 15 years, we've really started doing that. So I think here is the difference we can make to India. because I think we are a unique population. We are really unique population. So as we say, and she's correctly said, mechanical thrombectomy. We tell our patients, looking at just the Western data, that you can do mechanical thrombectomy even if you have a huge stroke. But that fellow, the recovery becomes from 10% to 20%. There are still 80% of patients who will remain bedridden and disabled, having spent 10 lakh rupees in the hospital. So that's a very difficult, issue to balance out. So I think we have to look at our own population and really focus on research, as she correctly pointed out, on what's happening in our population. How are the ambulances used in our populations? How is secondary prevention used in our populations? How is mechanical thrombectomy used in our population? How many people of mechanical thrombectomy actually are happy afterwards, and the families are happy? Because obviously the people doing it are happy, but are the families really happy with what we have done to them? And what are the outcomes in the long term to these patients? So I think these things need to be covered up in the Indian population. But I'm very happy that the Indian Stroke Association has grown and has really covered these gaps so well. And Jairaj is taking it to a next level, to the World Stroke Organization as well. So I'm really proud of that. We have an Indian who will head the World Stroke Organization shortly, and he's already started looking at these things carefully. And the Angels Initiative, which is the World Stroke Organization initiative, is also helping us bridge these gaps. In the state of Maharashtra, we are trying to bridge these gaps, having learned from Punjab and Himachal Pradesh, and to think about even telestroke thrombolysis, or at least think about these ideas of how to help strengthen the government, and not just the public private was a big divide when I started practice, and they have brought these two things together. So I think I congratulate them for trying to bridge the public private divide and create this. So even in Maharashtra, we have started looking at Himachal Pradesh, Punjab, how they did this telestroke project, how did they really implement this? Because we have about 30-40 CT scan centers in even the rural areas, but the utilization of them is really weak. I think we need to bring them up and give them the info. The problem with India sometimes is that it's not that the individuals are not good, but the systems are not connected. I think the real problem with India is the individuals are excellent, but the systems are not connected. And as it was correctly mentioned, the gaps and the weakest part of the system is sometimes the ambulance, sometimes the doctors also, I must confess, sometimes the centers themselves, sometimes the prevention therapy, and the rehabilitation, of course, exists as one of the weakest gaps, which I think Shailaja correctly mentioned. We haven't really focused on these things properly. We haven't really, and I think the public-private divide is all artificial. Somehow we always feel that there are the haves and the have-nots, but I think that's not true. I think it's just that the haves have to help the have-nots, and unless that happens, we are not going to get to the next level. But I congratulate the Indian Stroke Association and the team for building up so much in the 35 years that I have seen stroke. Thank you very much.
Thank you so much.
Can I just add a point with regard to what is the stroke research which has been relevant to the country? I'll just finish in 1 minute.
Please.
This is mostly with regard to, as rightly pointed out by Dr. Hastak, it is important to have research done in the areas where it is going to have an impact in our own population. There are many things we need to take from the developed countries, but there are certain areas which are specific to our own country. That way, if you can look at one of the work is with regard to the secondary prevention package study, which has been done from the Instruct Network, where how well the technology, like in the form of videos and messages and all that, can make an impact in the secondary prevention. That was one study which has been complete under the ICMR. Second is, as in the previous, I was just at the end of it, I was listening to the previous panel, it was talking about Ayush. We know that if you look at Kerala also, there are a lot of patients, because of their disability, after some time they go for Ayurvedic treatment. for which there was no evidence at all. And we were fortunate enough to do the first randomized controlled trial of Ayurvedic treatment versus conventional therapy. We were at least able to prove that Ayurveda is not superior, but we were at least able to prove that Ayurveda treatment is safe. So that is one thing which we could show from that data. And now there are 2 ongoing trials, which is very relevant to India, is with regard to intracranial atherosclerotic disease, which is a disease of the Asian population, where how long we need to give the antiplatelets, that is aspirin, clopidogrel, and all, for what duration, is being done by Dr. Rohit Bhatia, so that it is going to take some time for the data to come out, but that will be a very relevant question which needs to be answered in our own population, or whether we should go for early stenting versus we should still continue the medical treatment for those patients. And fourth, one of the major projects which is going on under the ICMR is with regard to the thrombolysis. Now we know that alteplase and tenecteplase both are very good. There is no superiority because it is alteplase is not inferior. We know both are equally good in the treatment, but we are using the biosimilar one. So there is this concern of whether the biosimilar is equally good. That is also one study which is going on the ICMR with regard to TNK versus TPA in thrombolysis. So I think, and as I mentioned earlier, that this emergency project is going to come. So I think the data from all these, the results from all these data is going to have impact in our own stroke population. Thank you.
Thank you so much, Dr. Shailja, Dr. Hastak, for bringing out all these points. So as we are very short on the time, and I would not like to extend more than the designated time, I will take the next question from all our 4 panelists as a consensus view. So from Dr. Marjorie, Dr. Gupta, Dr. Biplab, and Dr. Satish. Sir, as there are latest advances that are going on in the thrombectomy techniques, the techniques around stroke, but many of such techniques I'm not sure if are covered under the insurance policies that are currently available under health in India. So what are your thoughts? We would also want to know if all the different treatments and the upcoming latest treatments are covered under insurances, so that not just people who are below poverty line, but also people from the medium class who do not belong to below poverty line, special privileges, etc., are able to utilize health insurances for their treatments and do not hesitate towards going for, even the post care cost, that is the rehabilitation cost and all the different allied costs that comes with stroke. So what are your thoughts on the same? If you can touch upon the scenario that is there currently, and if there is work that is required in this aspect as well. So starting from Dr. Marjorie, ma'am, your thoughts. Yes.
I think it's a very important question that you have asked, because many times we are able to treat the patient in hospital and the hospital expenditure is taken care of by the Mediclaim people. But afterwards, the patient is left. And as the physiotherapy is most important, speech therapy is also most important, they are not able to, they get it done, but at their own cost, which may be sometimes very expensive. And in India, as you know, physiotherapy is one of the most expensive thing. For 1 hour, it may be close to 2,000 rupees, isn't it? About 2,000 in usual practice. So that is a little too much for anybody to spare from his own pocket, especially if you are not in the high earning category and you're not even in the low category group, so that nobody is helping you out and you have to shed it out from your own pocket. I think we have to do the government or us also, we have to do something about it to make it make a very important point to all the insurance companies to bring it in their ambit. But I think the CGHS does cover the physiotherapy at home as well as outside. CGHS is the one government agency which is helping the patient reimburse their physiotherapy. Yes, thank you.
Views from Dr. Satish, sir.
Yeah, so it's a interesting question pertaining to our country. I think majority of us who does mechanical thrombectomy in acute stroke care, as we rightly pointed out from the previous panelists, Dr. Shailaja ma'am and Dr. Hastak sir, are all in the corporate setup. Some central institutes are well covered with, flow of patients as well as the treatment modified through the central government schemes. But left are those where we don't have a comprehensive stroke team in state governments in each and every states. So, and none of them are doing the standard of care what is needed for the poor. Said that we are getting more and more young strokes who are in the most economically productive age group. So we need insurance backup for majority of them because or else the disability will be more. The point is people take insurances. Majority of the private insurances, including all the insurances available in our country, covers acute stroke care, both for first 24 hours up to the admission stay, including stenting and thrombolysis. But the point is the insurance, what the people are taking are very minimal, like in 2 lakhs, 5 lakhs. That doesn't cover mechanical thrombectomy, and they end up in shifting to a care where everything was done in the first one day in a beautiful way, but they don't because of the insurance and the cost, they shift to the centers where the comprehensive stroke team is not available and the outcome and disability changes. So I think we don't have any clear definitive answer for this. The central government, the state government, as well as the insurance policy makers, this is one among the treatment gap which is not asked before. So I think you have pointed out very rightly. So that is the need of the hour. And though we have teams at place, we don't have the other treatment gaps which is missed often. Yeah.
Thank you so much. Dr. Gupta, sir, your thoughts around the availability of insurance and people availing health insurance for their treatments for stroke. How common is it?
Actually, it is the same all over state, not only in Uttar Pradesh or other parts, but as central or LIC, these are the some features, some availability where the person can get the benefit. But the main thing is the devotion. There, likewise, previous speakers said, if we have the devoted medicals and paramedicals, the stroke can be managed earlier and the problems of the disability will be lesser. So my ultimately message is to all that we have to prevent the stroke as early as possible and the disability will be minimized. So whatever the question you have asked in front of all us, that is depends upon the government personalities, not only the minister or other persons, bureaucrats. They can help because stroke, as you know, as everyone knows, is the fifth major cause of the death in our country as well as in the world. So that is the important answer for the prevention of the stroke and its impact.
Thank you so much, sir. Dr. Das, I believe we have Dr. Viplab back with us. So your thoughts around the availability and equity around stroke. And I believe there is also one point being brought forward that most people do not even know what packages to get. So literacy around health insurance is also very much lacking, so that people buy the right packages and are able to avail the insurance services.
Yeah, Dr. Shah. Yeah, so my video is not working. I'm really sorry. I had to change my device.
No worries, so you can go on.
Anyway, so yeah, as you highlighted, it's very, very important, as Dr. Selja and Dr. Sish also highlighting that, the cost of getting treatment for a stroke, especially thrombectomy, is quite high in India, right? So for a middle class and the lower middle class, it's difficult to get mechanical thrombectomy, and it's not unfortunately we don't have a uniform system. I would say, I don't know, Dr. Salja might agree for that, because really private versus public system, so there is not uniform system in terms of how much cost it will cost for a mechanical thrombectomy. There's a huge gap in that way. We need to really work. We have done, no doubt, India is doing good for that one regarding stroke treatment and all. But there are lots of gaps where we need to do. And one of the points Dr. Salja already highlighted is like, the patients coming within the window time. If you look at that window time, is like within the window golden hours, hardly 3 to 4% or 5% patients come. So 80-90% patients don't reach within the golden hours, and we are talking about thrombectomy, thrombolysis. So rest of the patients come beyond after that one, and that's the importance of rehabilitation programs, which is quite lacking. And your point, as you made, that which are the insurance company covering or not? Yes, in private setup, usually mechanical thrombectomy and other things is well covered under all insurance company. But in government coverage, there are some it's not, as I said, it's not uniform system is not in place. I think administrations and from government point of view, they need to come out with a proper plan so that patients who are in the lower economic range or economic group, they should get benefit from this wonderful treatment.
Thank you so much, Dr. Das. We come down to the end of a super interesting episode. We could go on, and I wouldn't want to leave you guys before 1 or 2 hours. But as we are very short on time, we will wrap up this session now. Thank you so much to all our esteemed panelists for taking part. But before we close off this session, I would like to take one very quick key takeaway message from all the panelists for the audience that is watching as we are commemorating the World Stroke Day. So starting from Dr. Shirish. Sir.
Yeah, I think the key message, of course, is prevention, because I think we are a large country. We need the prevention to be properly implemented, and we need research around how we are actually doing prevention and how good we are at our prevention abilities.
Yeah, I think
and of course, controlling
the key message, of course, is prevention, because I think we are a large country, and we need
prevention still remains
properly
implemented in spite of the excitement around thrombolysis, research around how we are. And of course, the second key message is that we can get the policy makers to put in more effort into the rehab part in the and a large number of in spite of the excitement around thrombolysis as a result to the diet. And of course, the second key message is one of the policy makers to put in more effort into the rehab to move into art in a bigger way than what they have done in the past. So prevention and rehabilitation would be my key message to the people. Thank you
so much, sir. Dr. Shelja, ma'am, your key takeaway message.
Yeah, I think just as the theme of this year, I fully agree with Dr. Hastak that the key message is prevention. Even though we are talking about revascularization therapies, we are talking about mechanical thrombectomy, we are talking about treating these patients adequately, we know that all these patients are going to be disabled up to a significant number. So I think the message is with regard to, we know that 90% of the strokes are preventable. So have your risk factors very well controlled. It's not have your risk factors controlled. Please identify your risk factors. Have a regular checkup and find out whether you have a diabetes or you have a hypertension or you have got a hypercholesteremia. Treat them adequately and treat them very well controlled. It's not enough you take the medication. See that it is very well controlled. Exercise daily. Have your weight very well controlled. Do not have a sedentary life and prevent a stroke. And that is the best way to reduce the disability from stroke. Thank you.
Thank you so much, ma'am. Dr. Marjorie, ma'am, your key takeaway message.
Yeah, prevention, I think I will agree. There's no doubt on it. But start early and continue. That is, start early means reaching early and start your treatment early, starting your rehabilitation early. Those two things should be start early and reach early, and prevention. I would like to stress on these three things.
Thank you so much, ma'am. Dr. Satish, sir, your key takeaway message.
Yeah, so I completely agree with all the panelists. So
reaching early.
So prevention is the key. So learn from your family, from your parents and grandparents, or your risk of stroke. And if you are at risk, then I think modifiable risk factors can prevent up to 80 to 90% of stroke. So said that, the second important key point is map out your stroke ready hospital as well as your comprehensive stroke center wherever you are living. So that is the second important message, because the most important crucial decision making where to shift and how to treat is not being taken care of in the emergency setting. So these are all vital important points you should note before this is the message I want to say.
Thank you so much, Dr. Satish. Dr. Viplab, sir, your key takeaway message for the audience.
Yeah, so I agree with the other panelists, like prevention is better than cure. So healthy life and prevention. But before that, also I have to add is spread the awareness. That's very, very crucial. I mean, spread the awareness because stroke is preventable, stroke is treatable, and most importantly, stroke can be cured provided that the person reach to a stroke-ready center within the golden hour. That is possible.
Thank you so much, sir. Dr. Gupta, sir, your key takeaway message. If you can unmute yourself. So please unmute. Yes.
As earlier others said that prevention is the most important. With this, the not only the awareness is the most important, and everybody should know. The stroke-ready hospitals everywhere in district level as well as in most of the distant places will help the persons. And with this, the control of the blood pressure, diabetes, dyslipidemia is the main things to be controlled for the prevention of the stroke. And ultimately, devotion of persons like you and we and our medicals and paramedicals will help the society for the prevention of the stroke. That is the, and thank you you all for the awareness of the stroke for tomorrow and onwards. Thank you very much.
Thank you so much, sir. With that, we come down to the end of this very insightful discussion. I hope the audience was made aware on many different aspects around ischemic stroke and stroke in general through the 4th edition of Stroke Summit. Thank you so much. I would like to thank Dr. P.N. Shelja, Dr. Biplab Das, Dr. Shirish Hastak, Dr. Satish Kumar, Dr. Madhuri Behari, and Dr. D.S. Gupta for taking out time from their busy schedule, imparting us with wealth of knowledge and information on this topic today. Thank you so much. I would also like to thank all our audience for staying with us till the very end. Thank you so much. With that, we sign off now. Stay happy, stay healthy. Have a nice day. Bye-bye.
Thank you very much.
Thank you.
Recording stopped.